Okay, Shyam, you are centerfold. Share your desktop with us and then we'll all watch you.
Okay, let me just get down my presentation. Anyway, I think compared to, I think Zamir is very kind and is my colleague now. Can you hear me?
Shyam, just one second. Shyam, just one second.
Okay.
Can I please request everybody to switch your microphone off? Whoever is joining new, please switch off your microphone. Saransh, Galaxy 8, whoever this is, please switch off your microphones. And let Shyam take centerfold, please. Okay, Shyam, sorry about that.
Can you see the presentation?
Not at the moment, Shyam. You need to share your desktop.
Okay, let me do that.
Your share screen.
Okay.
Once you share screen, you will know immediately. Everything will become.
Okay. Let me go back. Yeah, let me just share the screen.
Yeah. Now we have got you, Shyam. We've got your screen.
Okay, you got my presentation there?
Not yet. We've got your screen, so you'll have to. We can see your websites and Zoom and all that. So stop your browser and bring up your presentation to the front.
Okay, I'll do that.
Or go into the PowerPoint's show.
Okay, PowerPoint show is on.
Okay, just give us a minute.
Is it better?
We can see. We could see your desktop before, but now we can see your face. So you probably click on the thing. Atul Abraham, just switch your phone off, your microphone off.
Yeah, there you
go. Okay, give us a second. It'll take a second. Yeah, we got it. We got it, Shyam. So that's fantastic. So just go full screen on it and yeah. Okay. Sure. Thank you.
Okay, can you see this?
Yes, we can see that. Fantastic, okay. Shyam. So the floor is all yours.
Okay, I think this is the Barth's Heart and Thorax Center. Zamir is our esteemed colleague and we're lucky to have him here. And he asked me to help you guys. I think the Pectus Excavatum has been there for since long time. And there's one of the first description you saw on one of the Da Vinci diagram where he showed one of the man with the Pectus Excavatum. I'm just showing off. This is how it all started. I think in UK, the practice is a little different. I'm a mixed practice cardiothoracic surgeon, but I think in UK, it's all changing. And I had one patient walking in my clinic with his mom. And I said, I had a referral letter saying that Pectus Excavatum. I said, take a shirt off. Then he wasn't. So his mom walked away. And then he took a shirt off. And I felt really bad. This is a teenager, was almost shy, if not worried, to take off shirt in front of mom. And I noticed that, and I saw her deep of her. And I didn't know what to do, because those days we only used to do ravage. So I described that. He said, do you know Nuss? I said, don't know. So I went back and read about it. Then I contacted several people. I went to US. But looking at the people doing the Nuss procedure, I said, probably that looks quite brutal and I won't do it. And then I met my hero or my guru called Hans Billegaard. It's on the left side. He has the largest experience in Nuss procedure in the world, one of the pioneer teacher. I just dropped him an email on summer holiday time. He said, come over. So I took, because it's summertime, I took my family, went to a small town in Denmark called Aarhus. And then he kept around 8 cases. I saw him doing it. He even let me scrub. And it looked like a magic show. But that's what I want to do. I learned, and in UK, it's a different system. You have to get a proctor, do certain cases, go through the governance. And that's how we established our Pectus services. Now we moved to St. Bartholomew's, and that's where we're doing it. So this is what I mean by Pectus Excavatum. If you look at here, that's the depression there, and the depression, and then more and more depressed. Then you calculate the depression index, and there are several, around 20 or depression index to Pectus index. But what is commonly known is called Heller index, which was described by Heller, who is a radiologist, recently passed away, to take a ratio of a horizontal diameter to vertical, and more the number, deeper the depression. And we consider, as a normal human being, our Heller index is around 2. And if it's more than 3.5, it's significant, and US insurance will pay for it. These are some of my previous operations. Others have done it. If you see the scar, they had a Ravitch operation, but then they regressed, and I had to come back and do that. So this is the report. In 1594, it was described about a chest wall, and also 1911, one of the surgeon tried. But the significant understanding of Pectus Excavatum came through Ravitch, and he described a surgical procedure. And up till now, still, we do the similar with different modification. Then a similar time, Donald Nuss, Professor Donald Nuss, he's in US, he had a lot of these patients, and then he thought of a process by which if you could lift the sternum up, then you can connect it. And he invented Nuss procedure. Being a nice doctor he is, he never took any sort of ownership of it. So people copied lots of different bars and stuff and started doing it. But it's thanks to this great man whom we met, all of us, we do this procedure now. It was initially popular for children, but my oldest patients are up to 50. I won't advise older than 40 unless really there is a problem. But I think younger they are, the better results you get. This is the famous Donald Nuss. He's still, I think he doesn't practice. Strangely enough, the large chap standing next to him was his first patient. He's now grown up, old man. He got it probably his children, but he had the first operation from Donald Nuss. So traditional scars are like that, big scars. Sometimes you get submammary scars. It's still a good operation. It takes a longer recovery. Only small thing is that they can regress over a period of time if you've done it in a little early age. And people who come for good scar, probably that's not a nice one to give them. These are my scars. The guy on the right side, he came specially from Canada. He's a lawyer, so I was quite worried. But we corrected his pectus, and he was happy. And the other guy on the 17 was my first patient who came walking to me and hiding his chest from his mother. So this is the Ravitch technique, where you do the midline, or whichever way you want to open up the chest. You have to dissect out the pecs, go back on cartilages and remove those cartilages which are wonky. And once you do that, you may have to do osteotomy, lift the sternum up. And to support the sternum up, people use mesh, people use bars, and then they close everything together. It takes up to around 6 weeks for full recovery, but the bars are usually removed within 6 months to a year, and you get a reasonably good cover. For till quite some time, this was the only option as a surgical intervention for that. So this is different type of scars, what to do with it. Looks quite brutal. Sometimes you do osteotomies, you have to fix the sternums. So overall, it's a major operation. So why did I change? A patient asked me to, and I thought we need to go further than that. I had so many inquiries for young people. I thought it might just work. So, and the scar was very small. And we have a revolution in the UK called choose and book. General practitioner can easily go online, see who can do what, and they just book it, and they are booked into your outpatients. I know it's a good system, but sometimes you may get a strange referrals to it. Once I had a almost 8-year-old boy walking in my clinic because of choosing book. I'm basically an adult surgeon. I do people up to 15, but not that younger one. So that's the issue. So this is how it is, the fact. It's around 1 in 400 to 1 in 1,000 births. It's around 5 to 1 male to female ratio. But it's very strange distribution. What I have seen is most of the South America, you get Pectus carinatum. Most of the North America, you get Pectus excavatum. Nobody knows what the reason is. One day we'll find a sort of a gene expression. And then I think me and Prof. Khan will give a name to it. But otherwise, they are usually, you don't see them that obviously when they're born, but over a period of time, they become more obvious. Around when you get a growth spurt, it becomes very obvious. There's a 40% familial history where it can be in the siblings, family, parents, uncles, and it's quite commonly seen in Marfan. Recently, we've done a few cases with a correction of a Marfan, and then we corrected their Nuss at a similar time. So what I was telling you about the Heller index is this. You do a CT scan and see how depressed it is compared to left and right. And then you do A plus B, so A by B, and that gives you the Heller index. And that's still been a traditional measurement of a depression index in Pectus excavatum. But there are several others, but I think this still works well because everyone needs a CT scan done. So what happens with Pectus excavatum? You could be perfectly normal, nobody knows, and you'll be fine. But if you do exercises, you get exercise tolerance. There's a lack of endurance, short breath. Some people have pain. I have a patient referred to me with a pectus who had arrhythmias because it's close to it, and we corrected a pectus, then arrhythmia disappeared. I had a patient who had a valve issues. We repaired the mitral and tricuspid, and then the correction of this. So there is this thing. There is a distinct paper sometime in morphology where there is a pediatrician, and along with his friends in histopathology, went through the records of postmortem, and out of 50,000 postmortem, they found around 60 odd patients of Pectus excavatum. Very strange statistics that what they found, that people who had a Pectus excavatum, most of them did not cross age 50. They died for different reasons. They are not blaming it Pectus, but that's how the interpretation was. And then if you cross 56, you could live longer. But that's how it's a strange pathological correlation. I can't take any credit, or neither I can endorse that if you got a Pectus excavatum, you will die early, but this was just a finding. So there are associated findings with these patients are asthma. It may not be asthma, but it could be because of the lung capacity. Scoliosis is reasonably common. And I had one of the wonderful letters. Usually as a surgeon, all you know, we never praise each other. We usually criticize or banter about anybody's surgical ability. But I had a letter from an orthopedic surgeon, who's a spinal surgeon, and he said, I was about to operate in this chap on his scoliosis, but you corrected his pectus with Nuss, and now his scoliosis disappeared. If it goes on, probably you'll put me out of job. I'm not taking great credit for it, but it's all linked together. If you look at the chest wall, it's all linked to the spine and the ribs and all. So if you correct one, it might just correct the other part of it. So these are some functional issues. There are tests, but what we found is that people do have a reduction in lung capacity. There is a cardiac function wise, you can have reduction in stroke volume, and quality of life wise, there are some proof in it. There are several tests on it, which proves that exercise tolerance will improve if you correct the pectus at the right time. So what we do is a CT scan, we do echocardiogram. If they're younger, we do MRI scan, it can give similar information. And then indication of surgery. The most important indication for surgery is if patient wants something. If you don't operate, they will do well without surgery, but they may have issues in the future about exercise tolerance, backache, scoliosis. So I think my feeling is between around 15 to 20. There's a good range of age where you can correct it. But otherwise, there are other treatments, like you see there's a silicone implant in this patient. So I think I'm going to talk about Nuss a little bit more because that's what I usually recommend to my patients. But if you have any questions and stuff, we can go through the Ravitch procedure stepwise. And there is a video of a Nuss procedure which we sort of modified. I will share with you. So I think to do Nuss procedure, most important thing is you should not be doing these operations where you don't have a backup of a cardiac surgeon, or you should be a cardiac surgeon yourself. And you must have a sternal saw and some facilities to rescue. Because once you see the operative procedure, there's a small chance, very tiny chance that you may damage the heart. And if you do that, you need to rescue the patient quickly. Otherwise, he could bleed to death. You need thoracoscope for this procedure. Usually we go from the right side. I usually like to use a 5mm 0 degree, but you can use a 30 degree. You don't need to double lumen tube. You can do it with a single lumen tube. You just have to disconnect it while you're dissecting it. My guru, you saw Prof. Pilagard uses epidural, but we don't. We just use a PCA, and then I use antibiotic afterwards because there's a metal underneath. This is all the concept and technique of a Nuss procedure. If you look at that, there is a sternal bar. This is a steel bar. You can also have a titanium bar, but if you get a titanium bar, you need to prefabricate them. These steel bar comes straight, and then we bend them as per patient's need and then use them. As you look at that, the stabilizer lies on the ribs, and the bar is pushing the sternum forward. Basically, that's what this operation does. Then we use short bar, and your x-ray will look something like that. You don't need stabilizers on both sides, but initially my advice is to use the stabilizers on both sides. So this is how we do. You put a little port on the right side, if you look at here, and then we put a telescope, inspect the depression. These are two markers. They show you the space in interspace and where you plan to put your dissectors. And once you mark that, then we take a template. This is a template. You measure it to design your bar. And then this is like a little carpentry shop. That's a bench bender. There are different bars you see here. And then you design as per template a bar which you need for your patient. These are some short bar, long bar. This is an uneven bar for a different kind of excavatum. And asymmetrical, you have to design the bar this way. And you can have a landing place and stuff. And if you see, the upper one here is a template, and the other one is a steel bar. There is always an issue that you must check with your patient whether they have an allergy to nickel or chromium, and if they have, then you may have to use a titanium bar. But this is how we measure bar, and then we mark the entry point and exit point with a pen, and then we pass this dissector under telescope so that you avoid going through the heart. And this is where you've got to be very careful, go across. And once you go across, you make an incision on opposite side and lift the sternum from both sides to sort of align the cartilages. Once you've done that, you take your bar with a little tape and then railroad it inside. Doing that, you avoid going again through any of the organs. So once the bar is inserted here, how it is, then we call flipping. We put the handles and flip the bar upside down so they lift the sternum up as it is shown here. And once that is done, half your procedure is over. Then you have to put the stabilizers. I'll show you those things once we finish the presentation. And they lie on the sternum. We pass on a little wire to prevent the stabilizers to move. and then we just close the subcutaneous and skin. So sometimes we need 2 bars, we use 2 dissectors. See how it looks like here, going across. If you're not careful, you go to other organs. And then we lift up. Then we can lift them up with the stabilizers. And then these are the one we flip it. And then we put a stabilizer on it. After flipping, we adjust the stabilizer on either side. And these are the some equipments. These are the short bar, and this is how it comes with a biomet. And we flip the bars again, if you see here, and they need to rotate. I'll show you in a video. Once we finish that, we de-air it with a radivac or a catheter underwater seal. We don't put a drain. Once a lung fully comes up, we close the wound. Then we do X-ray. There is no rush to do it, but some stage to see if there is no pneumothorax and the position of bar. And you always do left lateral to see the sternum is in front and above. And if you see here, this is the wire. If you see closely, that locks the bar in a position so it doesn't move. So these are some results. You have a sternum here before, and this is after. We put 2 bars. This was a chappy before. We have 2 bars, and this chap has just 1 bar before and after. See, look at it. He's even changed his underwear because he looks so good. So complications. You must remember, when we cut, we create problems, because without a cut, you can't create a complication. So every surgeon must know, you hold the knife, as Spider-Man said, that with a great power comes a greater responsibility. So when you cut, you should be able to deal with every complication you create. Because if you can't tackle with complication, probably you're not the right man for that surgery. So saying that briefly, complications are very small, but you can get a pneumothorax. Often we don't drain it, but you may require a chest drain. Occasionally they ooze and get you pneumothorax, hemothorax, and you need a drain. Sometimes you can damage a lung, they need airly. Sometimes it can damage the heart, and then you may have to fix it. I didn't have to do it, but some places, if you damage the heart, you need to fix that, and you can still do the Nuss procedure after sternotomy by fixing the sternum with the wires and then putting a bar. You can get infection, misplacement of the bar. Sometimes the bar flips, and then you may have to go back again. Pain is the main problem. I usually cover them for pain at least 2 to 4 weeks, because it's a medieval torture. You lifted him up with a bar and a bar underneath, and you sort of realign his whole rib cage. It's very sore. It will get a backaches and back. They find difficult to sleep on sides, and they shouldn't be, and they probably sleep on their back. Lastly, if you keep bar long enough, sometimes if they're old, you may have a problem doing CPR. So that's why the bar needs to come out between 2 to 3 years. So besides that, what I said to you about Nuss procedure, I'm quite a believer of that. I do that, but there are other things you can do. The Nuss procedure and the Ravitch procedures are corrections. Nuss is a minimally invasive correction. Ravitch is an extensive skeletal correction. But there's something called camouflage treatment, where you camouflage the defect by putting chest implant, cosmetic derma filler. There are some other gizmos came where they put a magnet under the sternum and put a magnet on the skin to pull the sternum up. I think it never worked. It was almost like birbal ki khichdi, where it's like to heating up a khichdi and light away. It didn't work. There are other non-surgical vacuum valve. Vacuum valve is a device where you put a vacuum on the chest and pull a sternum up. Very rarely works. I remember using once on the person with the Poland syndrome. As you know, Poland syndrome is where you have absent of anterior chest wall, rib cage, and it collapses down, and the child is always moribund because there is he can't breathe. So if you put a vacuum belt, it pulls the chest forward, gives them something to breathe. That's the only time I see it. The spirometry, exercise, physiotherapy, all these things have a limited effect. But if you're really scared of surgery, you may need to try that. But the braces work well in carinatum. So I think these are the mini magnet, or I think it's not worth even giving a second thought to it, but I have seen it. I very remotely thinks that it will ever work. Cosmetic dermal fillers, yes, they're good. It gives you good correction. But when they change their mind, it's quite a difficult thing. You have to squeeze it out from subcutaneous tissue, clear them up, and sometimes they migrate, go down, up, and things like that. And then you may have to take in back. Chest implants are not popular anymore because they're okay, but they're similar to breast implant. You can put it inside your chest and they can give you good correction, but you still have pectus excavatum. Often they migrate and you may have to remove them. You can see what's happening in UK, the timing wise. So this is the implant I removed before correcting. Quite a chunky size. These are some of them we removed before correcting. The vacuum bell, probably not worth talking, but it's something looks like that. You put it on, but it just bruises your skin so much. It's quite a large contraption. I think you get it from Germany, but I think very limited use. Spirometer is just sort of gives you incentive to breathe well. External braces are a good thing to use, but they probably are very good in pectus carinatum. As you know, pectus carinatum is a pigeon chest, and I see them more and more. And we used to do same as a ravage procedure for them. It was more for cosmetic for that because the lung volume or cardiac problems are very rare in pectus carinatum, where you have a pigeon chest. The operation is similar, where you take the cartilages out and push the sternum down, or osteotomy, and then it takes over a period of 6 weeks to 3 months to totally recover. But recently, the braces are fantastic. They are like a braces you put in the teeth, and you have to keep them for between 1 year to 18 months. And the regression of carinatum is phenomenal. Braces look somewhat like that. We have a different varieties of braces. The cheapest one you get it in UK is around 1,500. Costly ones are 3,800. They all are similar. What they do is just keep pressing your sternum. And then if you're young enough and elastic enough, they stay there. And once you start growing and once you stop growing, once you remove the braces, the chest look amazing. And recently, I got so many referrals on carinatum. I had to start a under 16 clinic, and we get almost 80% of those patients are carinatum, and we have a braces application service. There are two kind of braces we use, but I think the new one which we have is similar to what you see in the picture is one of the useful procedure to help them. I want to show you a video of the procedure while you guys are there, and then we can have a little chit chat. Is that okay, Zamit? I'll show the video now.
That's perfect.
Okay. Can you see it?
Not yet. There's a bit of a lag, but just wait, it will come up. You might have to stop your slideshow because put your slide down.
Okay.
The PowerPoint is coming in the forefront.
Okay.
So continue sharing and then show us your video.
Okay, let me just go on back here and then see if I have to share it again. Yeah, this one.
Yeah, okay, we can see the video now.
Go back and start again.
Yes, please.
Okay. I think if you hear me, this is a young boy we sort of modified a new procedure where you just need a single incision and double incision. And this is how we do workup, do a scan. And this is a Pectus Excavatum in theaters. And these are the wounds for a camera. And then you will see it, the video of what we did to this young chap. So this is a dissector going in. I have an assistant on one side, and this one, that's me. And the telescope is here. Somebody's watching on the other side. So we go across the sternum, and if you see it's poking out there, in reality, in our operation, we make a big incision there. But in this chap, we just put past a thread so that he'll have a tiny scar. And then we pull the thread up, as you must have known railroading. So we pre-prepared this bar, which looked like a curved bucket handle, which will go through inside the patient's chest. And then we watch through the telescope underneath. And once it goes in, it goes across. And we pull it on other side. It looks pretty brutal, this whole procedure. My anesthetist for 20 years usually closes her eyes this time because it looks quite a barbaric. But the results are fantastic. If you've done it nicely, the results are very good. You have to use a certain force so that they go across. And once it is gone across, interspace are narrow, so sometimes you struggle. See, once you've done it, this is called flipping. You flip the bar, and now it's gone down. You pull a screen up, and then you have to put a stabilizer, and then you fix it, the stabilizer, and see, that's one big incision, and that's the stabilizer you push in. And then you just keep it at faster speed, even though operation takes around half an hour, but you guys are busy, it's late there. So, and then we look inside, and then we put that wire to sort of lock the ratchet on the bar so that the stabilizer doesn't move. So that's the wire, it just goes locking the stabilizer. Yeah. This is how we de-air it with a little catheter, and then the closing one. You got two scars on the left side, right side, and this tiny scar. The results of this correction. Okay, I think I have showed you the video, and now I just want to show you the bars which I bought. So if you guys are watching it, this is the bar. I bent it, it's taken out from someone, and these are the stabilizers. See, if you put a bar through it, the stabilizer stays, so it prevents it to rotating. The stabilizer, what it does, it protects it, will prevent him from flipping or going inside. They stay on the lid and they protect it. These are the ribs, they stay there. You can fix the eyes to the ribs, it's not necessary, but this is the bar which I pre-designed. It's come out from someone, and these are the two stabilizers. We call it as a stabilizers. They're useful to prevent it from going inside the intercostal space and also for rotating. They're made out of steel. There are a couple of companies makes it, but if you posh enough, you can't make it in a gold, even though we are some Indian patients, because gold is very malleable. But if you want very costly one, titanium bar costs probably 3 times more, but they are usually reserved to use it in patients who have got allergy to nickel. I think I can take some questions.
Okay, Shyam, thank you very much. That was really, really fascinating. Before I get the juniors to ask a few questions, can I ask a few questions to just clarify a few points of the operation, and also to look at the literature. So my first question to you is, Shyam, in the original era, when we all started doing these Pectus bars, we were using the long bars which were curving on both sides of the chest, and we were putting stabilizers on both sides. Why did you change from putting stabilizers on both sides to putting stabilizer only on one side and using a short bar? Are you not worried that the bar will A, migrate, or B, flip over?
I think the problem with the long bars are they are quite long, and then the scars are always into your armpit, and you have to have a long, bigger scar. Second thing with that is that those patients had a lot of pain because they were sort of buried into your rib cage and pushing it. And it's unnecessary going beyond your armpit because rest of your chest is okay. Second thing is, if your bars are flipping, imagine as a bucket handle. If it's a long bar, if he flips it, it has been in historically transected someone's aorta by flipping backwards. And a lot of those people use long bars. They fix the bars to the rib cage with the wires or ethibond sutures or double sutures or a nylon wire sutures, double places. There are some surgeons do that all the time. There is a center in Germany. They use two long bar in every case. There's a center in Cleveland Clinic in Phoenix. I think Dawn uses one or two bars, long ones, and they do that. I change it because short bars are safer because they don't flip, and even if they flip, they will not cause any damage underlying structure. The pain with the shorter bar are less. And third, as a tradition, I learned from my guru, and he always used a short bar.
Yes.
And I didn't have any reason not to. But you can use a long bars, but long bars need more dissection, larger scars, and then often can be more painful because I have seen a long bars patients who take painkiller up to 6 months.
Okay.
Of course, you got a scar, submammary scar, tiny one, but if you have issues with that, then we may have to use a long bar to go into armpits.
Okay. So that's a very, very important point. And I'm asking these questions on behalf of the students to just clarify a few more.
Of course. No.
So my second question to you is, when you are operating on table, how do you decide whether you will use one bar, will you use two bars, or three bars? And how do you place the bars? What is the minimum distance between two bars if you do place it?
Okay, I think there are three different calculations for it. It depends on your height of your chest, then your elasticity of chest, how young you are, how skinny or things you are. The second thing is, it depends on how your deformity is. If your deformity is just below the sternal angle, often we can get away with one bar. But if it is more than that and it depressed from your sternal notch to zippy, one bar will not help you. So often you need two bars. And if you're really tall enough, then you probably need a three bars because your chest sternum is so long, then it's supporting. There is another small calculation. If you're under 60, the steel bar we use, one bar should suffice to take a pressure of a sternum. But if you're a muscular above 60 kilo, often the pressure from the sternum on a bar is not adequate, and that might just not give you good correction, and sometimes bar get flattened. To take away the weight, you probably need two bars. If you need a one bar, we go submammary incision where the maximum depression is. They usually in around fifth or fourth intercostal space. If you need a second bar, often you have to go high up. And when you go high up, you might have to make an incision on the right side, sort of near the nipple line, and dissect the pectoralis muscle and keep the bar high up. If you need further than that, you may have to take the same route and go above. Often these corrections don't help above the manubrium sternum, because you can imagine that is fixed with the clavicle, and that's not very mobile part. So you have to placement that. Important thing is usually you should have a gap of around at least a 2 inch space to get a better effect with the bars, but often you can't. I have put a crisscross bars, bar, oblique bar, because once I had a patient who had a small interspace and the sternum was very short. If I put a 2 bars, the second bar would have gone near the ZP and only rib cage was there. So what I did is I went from around 6 space on the left and the 4th space on the right. So it went a bit oblique, but it served the same purpose of lifting up sternum in the broader sense, because bar is around just about 1 centimeter diameter. And then if you make it oblique, it goes the distance of around 3 centimeters, and that can lift up the sternum a bit more better.
That's fantastic. So very important points for the students for exam going to know how to use 2 bars and what is the distance between the two. Now, other question is, when you see these patients clinically in the outpatient, you very often see what is called as a costal flare. So with the depression of the pectus excavatum, you get a costal flare where the side of the chest comes out. So when you correct these pectus excavatum, does the flare go down? Does it go in a reverse way?
I think the flare, because see, the Nuss procedure only moves the sternum forward.
Yeah.
Often it lifts the costal margin and gets a flare reduced. In some people it disappears. But often, as you asked me before, that sometimes to get rid of flare lower down, you may have to pass another bar, which lifts the costal margin. And because it's costal margin which is rolled down, gives you the flare. If you elevate that, it can go away. Very rarely when they are bad, then you may require a braces to suppress the costal flare.
Okay. What are the other bars available in the market? Nuss is 1 bar. There is something called as Abrahamson's bar, and every surgeon has come up with a new modification. So could you give us a name of some bars so that if you're asked in the exam, we can give them, I know about these bars.
Yeah, I think there is one which is a biomet, which is the very commonly used. The other one we call biotech, which is made in Budapest, and it's a sort of an orthopedic company who does that. I use quite often of those because some of the bar I designed for the reason of the thickness and their edges to move, and then so we designed some stabilizers because that can be difficult to put it on. There is called Medox, which is the guy who initially gone along with the Biomet. Then he made his own company where you get the stabilizers, where there's a screws and you can lock the stabilizers to the bar. There are several other companies where the names I don't know, but they come with the stabilizer on one side. It's a fixed position, so that needs to go in a skin and you rotate, so you don't need to do any that. But I feel it's very cumbersome and you may bruise the skin in those patients, and you get titanium bar. The Abrahamson, he's a sort of a South American surgeon, and there is someone called Mustafa Yüksel, who is in Turkey. They both have invented their own bars and stuff. The Abrahamson or a Yüksel procedure is for carinatum. As you saw, the bar is pushing forward. Their bar pushed the sternum downwards if you got a pigeon chest.
Yeah.
For that, the bar has to stay above the sternum, and then they are fixed to your ribs. It works in the small patients, but afterwards you can see a little bar under the skin and looks very ugly. I have seen Mustafa is a good friend of mine. I have watched him doing these cases. He does a technique called sandwich, where his 1 bar goes above, 1 goes in below, and he fixes them to the chest to rectify it. They look great on table, but in the long-term follow-up, the bar on the top can be visible under skin. Of course, these are not permanent solution. When you take out, it will be fine, but they very rarely work. And I'm very strong believer now that the braces do work much better than people give credit for that. There are several braces company in the world. It's like an orthodontic thing, how you fix your teeth. Same way they push it on the teeth and on the chest. There are some with a fancy one, it costs more, where you can measure the pressure from outside. Some which are not that fancy one, but they look like a really beautiful color stuff, because see, we're putting this on the children, and they have to accept it and wear it. If you make it something contraption come from the Star Wars, they may not use it. But if you make it something comfortable under their t-shirt, they might use it. So that's it.
The next question I want to ask you is, Pillegard a few years ago described the use of absorbable stabilizers on the side. And then I think a few years later he gave up. So tell us about absorbable stabilizers that Pillegard described.
Yeah, I think Pillegard wanted to see that because stabilizers, you need it for up to 6 weeks. And beyond that, their function is limited. And also, they are quite prominent, and patients usually complain of the stabilizers causing problem and things. But the absorbable ones were not very robust, and they usually had a crack in the back, and they didn't serve the purpose. They are probably made out of either a bone or not a bone, but it could be made out of a absorbable material, like how we had a PDS sutures, similar kind. But I think they couldn't find a material which was strong enough to hold them. But instead of that, you can use PDS sutures to wrap around, thick PDS sutures around your ribs, and that can serve same as stabilizing the bars.
Okay. And once you've put in the bar, how long do you keep it in? How do you decide when to take the bar out? And what is the technique of taking the bar out?
Okay, I think usually we keep them with max, earliest we can take out is 2 years. But Pillegard, we advise up to 3 years, because imagine if you operated on a 15, then by 18 the skeletal growth stops. So if you take out after 18, there won't be any regression. And that's the reason we remove bar. The earliest, very rarely you take out because of infection pain is 1 year. But if you take out within 1 year, the regression is up to 20%. So that's why it's better to do it every 3 years. More you wait, the problem can cause, because these bars get ossified around. And when you open up, you may not even identify them because it's covered with the calcium. You actually need a chisel and a hammer to locate them. Removal can be as dangerous or worse than insertion. We open both same scars, remove the wire, take out the stabilizers, and then we straighten the bar and pull it out without flipping it. You have to follow the path. There has been cases where people who were not very well versed with removal, they just pulled it out with a brute force, and the end of the bar slashed the right ventricle and create a disaster. So you have to follow the curve, respect the bar, respect the position where it is. But flipping them back is more dangerous because you will damage the mammary. Best is to straighten them, level them, and if you use a gentle force, they can easily come from left or right side.
Yeah, I remember David Whedon telling me, and he was my teacher, and he used to always tell me that if you, at the time of removal, you have to take the patient out of the bar, not the bar out of the patient. So the pressure should be on the patient, not on the bar. So that is just a anecdotal thing.
Yeah.
Now the next question I want to ask you is Donald Nuss usually operates on these kids when they are very early. Okay, 4, 6, 7. And the other guys, adult guys like you, operate slightly later. So what is the ideal age to put in a Nuss bar? And number 2, when you see them in the clinic, should you give them some time for the growth to be finished and stuff like that? So tell us, what is the youngest that you can put in, and what is an ideal age for the bar to go in?
I think after seeing so many nuts, I realized that younger you put it, the chances of regression high. Because recently I had a few referrals who had a nuss procedure as a child, as you said, 8 and 9. Then the bar was removed, and then as they grow, they had a regression again. I had to correct it. So my feeling is they usually, most of the nuss I see, the mother tells me that they noticed around age 13, because that's the ideal age to think about it. Why I'm saying it? Because living in a Britain, after 15, around 16, you do your GCSE. And once you do like a SSE, and once you do that, there's a large gap before you go to the senior level. So if you operate at that level and put a bar in, so that they have a big holiday to recover from a pain, and they're changing the school from the junior to senior, and they can go with a normal chest and nobody will notice it. And once they finish the GCSE, around 3 years time, you pull it out. So personally, I feel the earliest I do is around 15, but not before that, unless they have some problem like a valvular problem or arrhythmias. But otherwise, I would like to wait 15, 16.
What do you think about Pectus excavatum in adults? People who have finished their growing years, they come to you at 30 years of age, they are worried about the cosmetic deformity. Would you offer them surgery, or how would you select these patients for surgery?
I think we have started a little psychological analysis for some of these patients,
Yeah.
because uh, at that age, usually they have some issues because of the career, social, and they somehow feel that all their failure is linked to the depression in their chest.
Yes.
Those are the patients are very difficult to treat, because correcting them, you're not going to change their luck, and they will have the same issues. So those are the one has to go to the therapist to rule out sort of what you call a body dysmorphia, and then you need to have some sessions so they understand what you're going into. If they don't understand, and if you operate on them, probably you are not curing them. If at all, you're putting another problem in them, because then they will have pain issues. Then you have to treat the pain with pregabalin, gabapentin, and it just goes on till the bar comes out. Once you take a bar out, they're still under pain. So I think you've got to be very careful selecting it. But some of them, especially in the UK, is a different scenario. Till 10 years ago, as you know, Zamir, is that GP pushed away all the practices, or parents went to the general practice. There's nothing wrong with you. You're just a bit wonky. It will grow up, go away. And that's why they didn't get treated. And then they didn't have a chance to sort of argue with their parents once they are their own. And when they see the similar thing in their child, then they realize needs to be corrected. So probably, I don't know why it is, but I have done around 3 families where I operated on father first. I think it's a test drive. If I succeed in father, he brings his child afterwards, and I fix that too. So I feel that you can do as old. I had a very old patient who was probably a head teacher somewhere, but he changed his boyfriend, and the boyfriend was not happy with his chest. So just to please his boyfriend, he came to me. I didn't treat him on NHS because he was not eligible. He did in the private sector. He was in a tremendous pain for almost 3 months, but he recovered. But when he got all better chest, the boyfriend left him. So he corrected a chest. So there are different reasons. See, I usually have a frank discussion with them. And I tell them, if you do nothing, nothing will change. But some of the patient, I had to actually do it because they had tried all the arrhythmia treatment, and they're still going in those. And a person who had a syncope every time because of the closed bottom sternum, and they had a positive tilt test. Those are the one which I did it for a clinical need. But a lot of their postures and pain goes away once you correct.
Okay, my next question is related to these few comments you just made. So, do you think correction of a pectus excavatum is purely for cosmetic reasons, or is there data to suggest that pectus excavatum causes physiological problems to these patients over a period of time?
I think there are. I think there are enough evidence now that some patients, if you got a Heller index is beyond 3.5, it does affect you. If less than that, probably much affecting you about it. Because if you look at it, if this is a circle, the area under this circle is more than area under this, because that's how the Pectus Excavatum chest looks. So similar, the lung capacity, there are articles that the Hans Pillegard in his center, they did a study on cardiopulmonary exercise test and found that, as I told you, stroke volume can reduce up to 20%, lung volume can up to around 20-30% in these patients, and there are evidence that they improve. We have written a book on Pectus Excavatum and treatment along with the Hans Pillegard, and there's a chapter on physiological effect of this. But look this way, which I think our motto of our Grand Medical College was mens sana and corpore sana. That means you have healthy mind and healthy body. Of course, the treatment has to be physical, but these people also have a psychological issues with their well-being. And if as a doctor, we have to make it both sides better. And that young boy I spoke to you before, he was an introvert, shy person, came with a mom. But when he came for follow-up, he didn't have a mom, he had a girlfriend with him. And his life changed, he totally became extrovert. So isn't it, it's the sort of a gift of doing well, you get it. And that's why I look at them as a person who come to you finding a solution, and then you work along with it. You have to value risk evaluate with their well-being and everything else, and then you treat it. But you're absolutely right, almost around 30% of these patients are purely cosmetic. Around 70% do have some issues, and you need to work balancedly. But if they have a deep psychological issues, they should be corrected, talked about before treating.
Okay. My next question is, what about Pectus excavatum repair in females? Because obviously when they grow up with the breast coming up and things like that, the defect may be less visible. So do you actually do a deeper psychological profiling of these ladies, or do you treat them exactly like you would treat a male patient?
I think that's a really good question, because somehow I've managed to get quite a few female patients. One of them was lawyer. And the funny thing is, I learned in a business that she had this procedure, she got married, she had a baby. The baby, there was a big question what to do with the bar with the baby. I should just sit on it. So it worked out. Now the baby is out. And then she wanted to remove bar. I said, if you're lactating and you're feeding a child, you should not take a bar out. You finish the lactation stuff and then you remove the bar. And then she's coming next week for removal bar. So in ladies, actually, the scars are fantastic because it's hidden by breast. So it's much better. Second thing is, I get a lot of patients who already have a breast implant. And those are the complex ones, because you could literally damage to their 3,000 to 5,000 pound implants, and then you may have to pay for it or sort out. I almost had one patient who had a leaking implant, not because of me, it was. So removed the implant, we put a Nuss Bar, and then because we corrected it, she didn't need anything done to the breast, but she was so happy that she didn't want an implant. But it's a combination of it. Female patients probably are far more mature, and they are much more well-versed with what they want. But often they get ignored because you're absolutely right. If there is a good development of a breast, it's not very obvious, and they may not even come to you as a patient.
Okay, fantastic. Just for the postgraduate students, when you're talking in the exam with a Pectus patient, some of the papers that you have to remember, one is Donald Nuss et al. He's the main describer of this procedure. Lance Pillegard, who's a professor at Aarhus, as he described. Mustafa Yüksel has published a lot from Turkey. And there's a guy in South Korea called as Park. Okay, and Park has published a lot. So these are 3 or 4 papers that you must remember. Now, my question to you, Shyam, is Park has now come up with a new technique of 3D printing the prosthesis according to the specific need of individual patients. So rather than having a generic bar, he is doing a 3D profiling, 3D thing of the CT scan, and from there he is creating a 3D printed prosthesis. What do you think about this?
I think the 3D has been such a fashionable now. Everyone decide that even the heart valves can be designed on the 3D printer.
Okay.
Same thing, we had a big discussion with Yuxel, because Yuxel also have a 3D printing to do this. But look this way, the bar has to be very strong. Steel printing may be required rather than anything else you can do. If you get a fiber carbon steel printing. But these are, I personally feel, are more of a gimmicks.
Okay.
The 3D printer is good if you're doing the sternal, you get a sternum with a cartilage reconstruction. For suppose if you're doing a sternal sarcoma removal and there's absent chest wall, you can design that 3D print sternum and then you fix it to the ribs, and that will be quite a unique. And there is a space for it because you can use a material which is like a plasticky, which is easy to 3D print it. Metal 3D printing may be a bit difficult, and the strength of the bar has to be really strong. But yes, Park I come across. I was fortunate or unfortunate to do a case which he rejected because he thought it's almost impossible to do it. And I put on the spot without telling me that this was a Park has refused this patient. I had to go to Lucknow and do this case. It was as deep as it is. The sternum was touching his spine. I put 2 bars. It all worked out well. But I think Park has an extensive experience because the area he must be seeing the patients, phenomenal number of patients. And I think at that stage, as we are as a surgeon, we want to design our names to it. If the boys want to read it, my book is there at Springer, which is a concise, reasonably sized book. Will give you whole about a chest wall, what to do with it. And it also there on the Amazon and Springers, and there are PDF files which they can have a look at it, individual chapters. We concentrate more on the pain control, psychological thing. In my book, I also have a chapter written by a patient, so that how they felt and how it came across and how they felt afterwards. 3 of my patients who came to me did work experience, and now they're going to be in the medical school to be a doctor. I hope they don't take the chest wall surgery and operate on that.
Okay. So one more question. Shyam, it's okay with you, isn't it? I'm asking these questions for the benefit of these youngsters because they may not know what are the nitty-gritty of the techniques. So just one quick question. Shyam, we've had not you, but the Pectus community in the world at large has had some spectacular complications, which have been picked up by the press, and the government has also sometimes come down very hard on the Pectus practice. That's one side of the story. And the other side is with the internet being so widely available and these patients Googling everything and people putting up their best photographs out there of outcomes, the expectation from these patients is unrealistic sometimes. So can you address these 2 issues? One is the issue of the supramajor complications that have been reported in literature and in press. Some people have even lost their license because of that. And number 2, the unrealistic expectation of the patients.
Yes, I think there are 2 issues with it. And one of them is if you really want to find how the Pectus has this. There's a book written by a mother, and it's available on Amazon called Nuss Killed My Daughter. And that's the title of that book. This is a story of a very shy young lady who was teased and bullied in school because of her chest. She didn't need a correction as such, it wasn't affecting, but she went to the correction. Correction was reasonably good. Then she developed complications of wound infection and stuff. And then the bar removal. While removing the bar, The surgeon managed to tear through the right ventricle. By the time they went in and fixed that, she had a hypoxic brain damage and she died. And because of that, one of the institute in UK, they had to stop doing this. And that's how I got all their patients coming to me. And that's the issue. Second thing is, this is not a life-saving operation, but can lead to a life-threatening complications. And that's the reason we got to be serious enough and strong enough to describe, justify. Eventually, it will come to us that every patient, we may have to, like a multidisciplinary team meeting where you discuss with every facet and come to a treatment. Because the complications, if you have in these patients of life-threatening, then you're absolutely right, we will have issues with it. The most important thing for it, we are developing a software soon where we do 3D scanning on these patients externally with infrared cameras. But we are developing software where you take a patient's 3D image, show him that, and then on the screen you show them what correction is possible by Nuss procedure and show them how it will look like. And they have to take that back and think whether this is how their chest looks like. And if they think their chest looks like that you want, then you have to give them, I tell them frankly, I said, this procedure only lifts your sternum. It's a lottery afterwards. What else comes with it? Sometimes you might get a really six packs because you lifted a rectus along with it. Sometimes your flare will disappear, you'll totally fine. Sometimes you'll still stay, I can guarantee your sternum will be forward. But what goes with it is not always promisable with this. And if that is what you want, go ahead with this. I tell them the realistic view of the pain. I said it can go up to 4 weeks, if not more. Second thing, we tell them that you can't sleep on your back, on the side for almost up to 6 weeks. And that is also, they need to accept that. And all these things, once they accept, then only you go through it. And if you think they have issues, then we refer them to a psychologist to analyze and decide whether they are sound mind to accept the treatment. You're absolutely right. These are the cases. We still have a review from NHS England about commissioning them on the NHS. At present, they are too busy with Brexit, so they are not focused it. But I think eventually we'll have a rationing on it because anybody about 20 probably will not get NHS funding. There are some commissioning bodies in the UK, they will not okay it. I feel that's sad. Of course, by private practice, we can get more patients to it, but important thing you must always remember, what goes out of NHS, it gets more scrutinized if it only goes to private sector, because there could be some bad apples who can exploit this for their own advantage. So I think we should never forget that we are a surgeon and a doctor first, and then profiteer afterwards. And if we must take it every case, discuss this thing. And children, it's very easy. But I have a patient who was corrected by pillar guard front of me. And this guy had, it was such a minuscule, he had 2.5 Heller index. We created it, looked well, but he wasn't very happy with it. And now he doesn't want me to take a bar out. The bar is not, but he wants me to take a bar out and correct it again. He went through all this. And I said, you can't correct beyond that. For me, from outside, it looks all perfectly fine. Your normal chest, I can't correct. We keep chasing up. So I have referred him to the psychologist now again to see what he wants. But that one patient, as you said, we must watch it. Because if you do anything to him, you probably will harm him more than the benefit.
Okay, so for the sake of the exam going, guys, when you are discussing pectus surgeries, don't forget to mention the role of a psychologist in the team. It's quite important. Now, just the last question before I ask all these guys to ask you questions. Could you name us some syndromes in which pectus is part of the syndrome? And please give us one-line explanation of each syndrome so that they can talk about it in the exam and appear knowledgeable.
Oh, no, good. One of them is Ehlers-Danlos syndrome, or ED, which goes with your mucin part of the collagen, which is defective, and they get a full range of it. These are familial, and you can see genetically transmitted in different I think it's autosomal dominant. And you can see in the babies, the problem with that is it makes your aorta very elastic. And you can get aneurysm of aorta, elastic fingers, aorta can rupture. So those are the patients can have pectus excavatum rather than carinatum. And often if they need aortic surgery, you can also correct the chest. But you must remember they're very elastic. And trying to correct it, you've got to be very careful because the ribs are elastic. If the finger stabilizes, they can cause a depression in those patients. The other one is a Marfan syndrome, which is common. You get aortic valve problems. There are other syndromes you want to throw out. It's called Poland syndrome, which is usually seen absent
Poland.
of
We didn't catch that name. Poland syndrome. Poland.
Yeah, that's a life-threatening. The child is born, usually gets shoulder dystocia because the shoulder is developed. When you come out, you get a sunken chest where they can't breathe, and if you don't treat it, they usually die. You have to put them on a ventilator and then try to correct chest, or put them on a ventilator till it stabilizes the sunken part of it, or you need a vacuum bell initially to do it. And then these are the ones you may require a 3D printer to create this artificial chest wall out of a PDS, or not PDS, but from the plastic, and you can stitch it up.
Okay. And last question, what is the etiology of a pectus? Is it congenital? Is it genetic? When they write an answer in the theory, what is the etiology of pectus?
I think etiology, there are two ways you can do it. One of them is we don't found a gene, a sort of marker or a location of the defect on any of the chromosomes yet. But we might find it. They have a correlation with the Ehlers-Danlos and Marfan because that's the defect, but not in this thing. But it's more common familiar than that it is transmitted by any of the autosomal or recessive. But it shows into families. It's not always there when you're born, but around your growth, around 8 to 13, it gets more obviously seen. So we feel if you keep calling it congenital, often the insurance doesn't get improved. But it is congenital in a way, but you're not born with it, but it gets reverted. So our hypothesis is these are external and intrinsic factors where intrauterine pressures can cause a problem with the development of chest wall. External factor, which we have hypothesized, is that when the cartilage and the rib get docked in and you're growing it, there should be a growth, sort of a reduction of a growth in where they are docking in. But if it's not controlled by some of the messengers, then the goes carrying on. And because the rib is growing and cartilage is docked in, either it pushes the cartilage along with the sternum anteriorly or posteriorly, depending on carinatum excavatum. So there must be some messenger issues with carrying on to the growth of cartilage, ribs, and sternum.
Okay. And when you investigate these patients, you do an X-ray chest AP lateral. You would do a CT scan to identify the Haller's index.
Yeah.
What is the role of MRI in delineating chest wall deformities?
I think MRI don't have it in this one, but because if the child, if he's a child, exposing early age to CT scan will have his issues. And that's why in the children under 16, I usually ask them to do MRI, because what you want to see is how close the sternum is from the heart. And also it gives you the heart. And we do echocardiogram because they can associate cardiac anomalies, and also shows you how close the heart is from the sternum.
So in the workup, the cardiac workup is very important, isn't it?
Cardiac, and also you do lung function, because if you're doing the volumes, then you can show in the future whether they improve or not.
Absolutely correct. Now I'm going to throw this forum open to all the participants. One by one, switch on your microphone and ask question. This is the time for you to ask question. Shyam is a very, very busy man, and we're very fortunate to get him on the spot to talk to us. So let's take this opportunity and ask him as many questions as you like. So go ahead, guys. I have asked a lot of questions on your behalf, but let's get everybody else involved. Okay. particularly the exam going?
Sir, Amol here, sir.
Okay, Amol, tell us.
Yes, sir.
I am all.
Sir, yes, sir. Sir, where exactly the stabilizer lies? It's under skin or it's under pectoralis major muscle? Is it annoying to the patient when they touch that area?
Okay, the stabilizers lie above the rib and under the skin, not under the muscle, because where we put on there is very little muscle. If you're skinny enough, you can feel it, but often because of the reaction, they get padded off. But if you're really, really skinny, some of my patients are, you can feel it when you touch it. But otherwise, they are, and they can cause a problem. They can cause a depression, and often the depression, there's a lot of patients are bothered with, and then you may have to wait till the bar removes, then the correction can. If you put a bars above the nipple, then the stabilizers stay under the pectoralis muscle.
Okay, sir. Sir, second question. As I saw in the video which you shown, that while turning the bar, flipping the bar, we might injure the intercostal vessels also. How to avoid injuring? How to avoid this complication?
I think that's important thing is if you're very close to the sternum, then you can damage internal mammary artery. But if you dissect, if you keep repeating dissection, keep repeating pushing and pulling the bar, then your chance of damaging intercostal vessels are high. So it has to be done slickly in one motion. Don't keep move out the bars and push it back again. Follow the path and do it gently while you're pushing it, because you're going through, as you said, and the worst one is intercostal artery. But once you flip it, because anatomically internal mammary lies between a groove between sternum and ribs. So when you flip it, it doesn't damage the internal mammary artery. When you remove the bar, you don't damage the mammary artery. But intercostal arteries can be damaged if you keep repeatedly pushing it. So avoid pushing repeatedly. Do it gently. Do it in one go, then you will avoid doing it.
Thank you, sir. Thank you.
Thank you. I think there's a guy in Delhi, I forgot his name, Shalom or something.
Yeah, Darlong.
Yeah, he does some, and he
does
got his own bars, and he puts some plates and stuff. He's quite innovative. He's got a very entertaining website. And I think he has pushed it boundaries there.
Yeah, but some of these, you got to be careful about what plates you're using and what innovations you're using, because all plates are considered as medical devices. And even within the Indian setup, in fact, it's very, very, very difficult to get a DGCI clearance for a new medical device until and unless you have done randomized control study and you've done phase 1, phase 2, phase 3 study. So a lot of innovations that are being used have been used, but if you get into medical legal trouble, then you are in big trouble. So you got to be very careful that if you make an innovation and you make a new device, because every time you make a change, it is essentially a new device, you need to get the licensing from the government quite clearly. So this is just a warning for all you guys, because if you're going to be operating on pectus, don't think that you can go to your local shop and get a little steel bar and bend it into position, because that bar is not authorized by the DGCI. So, it's very important that whatever you do, use devices that are legally authorized. It's just a caution for the new surgeons, because I have myself seen lots happening in India, and we got to be careful about these things.
Of course, it's going in someone's body. You've got to be careful. It's tested.
You've got to be very careful.
And it's the safest one you can use.
Yeah. Okay. Next question, please.
Sir, one more question, sir.
Yes, Amol.
Sir, Yes, sir. The bars which you are using, are they MRI compatible? Because we might need to follow up these patients later on.
I think they're steel, so they are not MRI compatible.
Not MRI.
And they can be done a CT scan, but I won't advise them to go in MRI.
Yeah. When these
Yes.
people travel, they have to actually carry a doctor's certificate because they do get highlighted in the airport security. Shyam mentioned in his slides, airport security is an issue. So you got to be careful. You need a doctor's certificate. Otherwise, you could get arrested. So
No, I get they give them a letter and then ask them to take a picture of the X-ray, put it on their mobile phone, smartphone.
Yeah.
So when they ask what you have, you show them that, and there is a letter saying that he's got an implant, and often they let them go.
Yes,
Okay.
sir. Thank you, sir.
Next question, please. Shyam, are you okay for a few more minutes?
Yeah, fine.
Okay, thank you. Any more questions from the audience, please?
Kamal or Bhushan?
Sir, I have a question. My question is, sir, during your talk, you mentioned that if the titanium bars can't modulate on table. So what do we do for that?
So if you want to...
Shyam, just 1 second. Shyam, just 1 second.
Yeah.
Guys, when you ask a question, put your video on so that Shyam can see who he's talking to. Okay, thanks. Shyam, all yours.
I think the titanium is very difficult to bend. There are systems you can bend, but they're pretty costly. So what we do is, if you need a titanium bar, we send you a CT scan, and then we mark them which space we're going to use. So, and we tell them all the requirements. Then the company designs the bar and bends it for us and send it to you. They're pre-bent. So once you insert, as I showed you how you insert it, but once you flip it, you can fix it, but minor bending may be possible, but it has to be accurate. So you need to do a skeletal scan of your chest wall and send it to the company to design it, mark the areas, entry point, exit point, where to bend it, and they send it. They are very, very helpful, but that's what you have to do. If you need them to bend, then there are special devices, they're made out of titanium, can give you little correction, but you can't do major bending because they can crack.
Okay. Next question.
Thank you, sir.
Next question, please. Nikhil?
Yes, sir.
Are you asking a question?
No, sir.
Okay, all right. You came up on the screen, so I thought you were asking a question. Okay, anybody else wants to ask a question to Dr. Yes? Okay, no questions.
Okay.
So Shyam, thank you very much for this fantastic talk. It was really an eye-opener, and it's just amazing to see how good a cosmetic correction that we can get with these things. So just to summarize your talk, we have got Pectus Excavatum and then we have Pectus carinatum. Both of these can cause severe psychological problems for patients, hence they look for corrections. They can also cause physiological issues. There are techniques how you work them up preoperatively up to the surgery. Intraoperatively, there is the open technique, and then there is the minimally invasive technique, which Shyam is an expert on. So Nuss Bar is the standard across the world nowadays. And there are complications that you have to remember about. Okay, and there are a lot of questions about the type of bar that you can use and the type of stabilizers and the number of bars. Okay, so Dr. Kolvekar, thank you very much for your time and effort. It's been a fantastic and absolutely brilliant lecture, and I'm pretty certain everybody in the group will agree to that. And I think, can you give us a link to your textbook, Shyam? Have you got it on your computer screen?
Yeah, I can. Let me see.
Show it to us. I'll put you on and show it to us. If you can show us the textbook.
I'll show you the book, just a second.
Yeah, if you've got a book, just to show it. Wasn't that a brilliant lecture, guys? Fantastic, absolutely fantastic.
That's the book?
Yeah, just zoom in. Okay, can everybody see it? Okay, so chest wall.
I'll send you the link on it, and then you can. Let me just get that on.
Okay, just to wait for a second, guys.
Shall I send a text on this one?
Send me on the WhatsApp group a
Okay.
picture of that, and we will all then catch up with it. Okay, guys, if you've got no more questions, then we will call it a day.